All right, here we go, CC5, week 10. We are still working on the ear, and this is all the farther I got given the circumstances of me getting this class. So here we go. Where have we been? So we've been talking about the anatomy of the ear, the external ear and the internal ear, and the middle ear. We left off on these three tiny bones that live in the middle ear. They're called the auditory ossicles. There's the malleus incus stapes, or miss is the analogy some use. The hammer, anvil, stirrup are old AKAs. I don't think you'll see those on boards anymore. Auditory ossicles, what do they do? Or what can you consider them? Some consider them an articulated chain, meaning that if they're articulated, that means they have joints and they're tiny bones, and they transmit vibration of the eardrum or the tympanic membrane to the cochlea of the inner ear, which of course is where hearing occurs. You could also say that they connect the lateral medial walls of the inner ear together, and they contain two movable joints which have names. Okay, malleus is this, incus, stapes, and we see a joint right here. So this is called almost like atlas and always gets named first, like atlantoaxial and atlanto-occipital. The incus always gets named first. So we have incudo and then malleolar for malleus. So incudo malleolar joint is right here. And that is a true diarthrodial joint, and it's even agreed upon that's a saddle joint. Then we have the joint down here between the stapes and the incus, so that's incudo-stapial joint. That's more debatable. It does have a synovial membrane. It has a capsule, so it is a synovial type joint, but there's not much synovial fluid, so that one's a little bit debatable. Here's the parts. I don't expect you to know all these parts. I'm sure you had to learn them for Gross 2 anatomy at one point, but there's the parts. I'm not going to test you on those. The concept of the ossicular chain. Sometimes some people call that the primary sound conduction apparatus. So collectively, the auditory ossicles make up what's called the ossicular chain. Where does it live? That's within the petraeus portion of the temporal bone. What is its job? Well, we said it transfers vibrations that comes off the eardrum, tympanic membrane, and yep, that's what it does. We'll look more specifically at that in a minute. It actually amplifies the vibrations. We'll save that slide for a little later. Can you live without these bones in your ear, these auditory ossicles? What if you lose them? Can you survive? Yeah. But not very much. It takes sound down to, you have a sound loss of 55 decibels, which is significant. And the difference between 55 decibels is a very loud voice. I won't talk super loud because I'll redline my mic here. But that's the difference between a very loud voice and a whisper. So if you talk to somebody with an ossicular chain malformation or pathology, you have to talk in a very loud voice just so they can barely hear you. And we can have some problems with this ossicular chain. And one problem, a common problem, is a dislocation or even a subluxation of either of these two joints. And if that occurs, you're going to lose 55 decibels if it's a significant dislocation. Well, how in the world does that happen? Well, usually it's by some type of trauma, but let's see, what is this slide? The ossicular chain dislocation, it results, I see. It results in what type of hearing loss? A conductive hearing loss. Remember, hearing loss, conduction, is through the external ear, which includes its kind of sound is caught by the external cartilage part of the ear. It's transferred down this auditory tube here, and then the middle ear. So the outer ear and the middle ear That's where conduction occurs. And yeah. So this is a very cool picture right here. As I said before, the number one cause of these ossicular chain dislocations is from head trauma. More specifically, usually motor vehicle accidents, especially broadside type accidents, falls, slip and falls where you don't have time to catch yourself, and fights, getting hit in the side of the head. And here is the includostapial joint is viewed right here in this patient with significant hearing loss. They had a motor vehicle accident. About a year later, they still can't hear. And they went in and they cut back the tympanic membrane so you can actually see the auditory ossicles. And we can see the incus and the stapes, or the includostapial joint, right here. If you look closely, you can see that is calcified shut because it dislocated, and the dislocation turned into an inflammation. Fibroblasts lay down scar tissue, and scar tissue sometimes calcifies. And so in the surgical procedure, they're trying to, and they actually did, they're able to scrape this. You can see this little kind of curved device here. They picked away at this and over and picked and picked and picked. They finally broke this loose again. And the doctor said that it will, now that they got the calcium out, it's got at least a chance of working again. Trouble is it could calcify shut again. But anyway, very cool picture. All right. How about some other causes of these ossicular chain dislocations? Every now and then it happens and there's no reason for it. It's probably somebody's lying, I bet, about getting hit in the side of the head. But blast trauma from a bomb going off or dynamite going off, barotrauma, where you go deep into the ocean without regulating, without equalizing the pressure between your oropharynx and the middle ear. What is the treatment? And I didn't want to get too deep in this, so I've already cut slides out because I was getting into the weeds in this ossiculoplasty, but we'll just say that's the procedure. This is an ossiculoplasty where he's trying to fix this joint, is one form of it. Sometimes they can try to put fake bones in, so it's a big subject and that's too deep for us. Just know that they're not going to have perfect hearing. Maybe they might. You won't have to yell at them so loud for them to hear anything. That's kind of the improvement, maybe get a 50% gain. Back to the auditory ossicles, just some closing, some more fun facts about them. The malleus is the largest of the three. We already said they're all covered by a mucosal type tissue. And the malleolar handle right here is connected to the tympanic membrane, which would be kind of, I could draw it like that. So this whole thing is connected to it. The tip of it is connected to the perfect center of the membrane, tympanic membrane. And then we have a muscle. There's a tensor tympani muscle that's also connected to the malleolus. We need to look at them in a minute. The incus sometimes is called an anvil, even though, I don't know how that looks like an anvil. Looks more like a tooth to me, and that's what this author called it, a premolar tooth. And it forms an articulation with both the malleus and the stapedius. We talked about the incumalleolar and incustapedial joints. And the stapes is known as the stirrup, and that kind of does look like a stirrup. Right. More fun facts. The stapes is connected to the membranous labyrinth of the cochlea via the oval window, not the round to the ground window, the oval window. And then we have tiny ligaments that secure these articulations in place. We won't worry about the names of them, but there is a nice thick ligament right here connecting to the malleus, and another ligament connecting to the stape or the incus here. Right? There's a Stapedius muscle, and there's the tensor tympani muscle. We're going to talk about more here in a second. Okay, now I promised a little physiology. So what exactly does this auditory ossicles do, this chain of ossicles, chain of little bones? So we said they transfer sound from the eardrum into the inner ear so you can hear. More specifically, these bones are arranged in such a way that the sound waves are actually increased. They used to think they were decreased. When I went to school, they thought that you lost some of the force of the sound wave, some of the frequency of the sound wave. They actually increase it by 1.3 times, but that 1.3 times increase in sound wave force hits the fluid of the cochlea 22 times harder than it would if there was no bones there at all. So it really increases the force coming in, the force of vibration entering the fluid that's in the cochlea. And that's needed to overcome the increased fluid density of cochlear fluid. Without the auditory ossicles present, or if they're frozen or ankylosed, sound wave can still hit the oval window, but at least this author said the hearing is decreased by 20 decibels in this situation. And again, it makes regular speech barely audible. All right, the muscle, so tensor tympani muscle, we can see it right here. So it lives in a little bony canal, has its own little canal, and it lives right above the pharyngotympanic tube. Okay, we can see that, or aka the eustachian tube. It's right here. Remember that eustachian tube? It equalizes pressure between the atmosphere, or the nasopharynx, and the middle ear here. And it arises from a cartilage, basically the cartilaginous portion of the pharyngotympanic tube. It inserts into the handle of the malleus near its root. You can see it. There's the malleus right there. And you can see it inserting right here. Okay. It's important to know the nerve that supplies this. I think we've mentioned that before, but you could say there's 3 possible choices depending on how deep the question is. The easiest question will say it's supplied by the trigeminal nerve. The next depth of the question, like a medium hard question, would say it's supplied by the mandibular division, or V3, of the trigeminal nerve, which is cranial nerve 5. Or they could get really crazy into the weeds. There's a branch of the mandibular nerve called the nerve to the medial pterygoid. And that's the true nerve that supplies it. So who knows? So why do I care about this? Well, what happens if you get a tumor and it compresses this nerve to the medial pterygoid? Well, the tensor tympani is not going to work anymore if the lesion is damaging that nerve. Well, who cares about that? Well, we'll find out here in a second. Because what is the job of the tensor tympani muscle? It pulls the handle of the malleolus medially, medially inward toward the inner ear, and that does 2 things. It makes the tympanic membrane very tight, so sound waves hit it and it can vibrate. Right? If it's limp and loose, the sound waves aren't going to do anything to it. It's got to be really taut. And then, just as importantly, it can dampen or decrease really, really damaging loud sounds by pulling. And there's the cartoon of it right there. So it would be pulling it this way, kind of toward the cochlea, and it has the ability to dampen sounds. It has to be in combination with the stapedius. In fact, the stapedius muscle is more important, tensor tympani, for dampening these sounds. Tensor tympani pulls the inner ossicles this way, stapedius pushes them that way. So these 2 muscles kind of compress these auditory ossicles to the point they don't work. And that deadens the vibration through here, so the cochlea isn't hit with super crazy high sound waves. All right, so that's the story with that. The stapedius arises from the posterior wall of the middle ear. Okay, has nothing to do with the eustachian tube. attaches to the neck of the stapes. That makes sense. Stapes attaches to Stapedius, or tensor tympani attaches to the malleus. I don't know why they didn't name it like tensor malleolus or something, but they didn't. The Stapedius has a claim to fame. It is the smallest, or Stapedius has a claim to fame. It is the smallest skeletal muscle in the human body. It's only about 1 millimeter in length, so it's super, super tiny. Even though it is so tiny, it still, of course, has to have a nerve innervation, and it's innervated by a branch of the facial nerve. Let's leave it at that. It pulls the action when it contracts. It pulls the Stapedius laterally, or more toward the outer ear when contracted. It's just the opposite of the action of tensor tympani, and it helps to deaden excessive sound vibration, just like tensor tympani does. Again, they act in concert, and here's a slide on that principle. They act together. So when contracted, they increase the rigidity of the entire ossicular system, or the auditory ossicles, which decreases the ability for those little bones to transmit sound, especially loud sound. And that brings us to something I'm sure you've already had in physiology, I hope, and that is the attenuation reflex, which has all kinds of AKAs: intertympanic muscle reflex, auditory reflex, Stapedius reflex, stapedial reflex, middle ear muscle reflex, or MEMUR. I'm just going to call it, from Guyton uses and Standring use, the attenuation reflex, so that's what I'm going to call it. So there's a reflex that occurs when really, really strong, forceful sound hits your outer ear and basically hits your eardrum. And there's a reflex contraction of both of these muscles very, very fast, which protects the inner ear from extremely high damage. It's a reflex. And it's not only sound waves. This reflex also deadens the sound of your own voice inside your head. Let's everybody do an experiment right now. If you put your fingers in your ears and you talk, what happens? You hear how loud that is? So that reflex that's as if the reflex isn't there. Okay, so it deadens that talking as well, so we don't hear that sound. I think I have a slide coming. I'm getting off my slides, which I shouldn't do because these are brand new slides and this is not my course. Okay, and yeah, so it decreases the perception of hearing. And if you want to get technical, most of the deadening is 1,000 hertz and below. So it's the low mid ranges and the lows that are taken out, and those are more damaging to the inner ear. And that actually is where mumbling background noise is too. So you want to remove that so you can hear crisp, clear talking when you're in a crowded environment. You got to know the nerves of these of this pathway. So the afferents are transmitted down the vestibular cochlear nerve. That's cranial nerve 8. And the efferent motor part of it that goes out to the muscles is the facial nerve for the Stapedius, and the trigeminal nerve for tensor tympani. There's one more as well. What am I missing? Facial nerve. No, we got that. There it is, trigeminal right there. I was going to say, I thought there was 3. So the efferent pathway is double facial nerve and trigeminal nerve. Okay, what's the function of this reflex? We already said it protects the cochlea from excessively vibrating sound waves that could damage it. And it also masks low frequency sound in a low environment. So it takes away background noises and it makes it easier to hear, and it takes away that your own speaking voice, and so you don't hear it inside your head as well. So 3 things. So it masks low frequency in a loud, noisy environment, protects the cochlea from excessive, super loud sounds, and then it decreases the person's hearing sensitivity sensitivity to his or her own voice. By lowering, it lowers about 35 decibels when I'm lecturing right now. This is going on inside my auditory ossicles right now. I didn't put this on, but it should. I'm sure they talked about this in physiology. This attenuation reflex is quick, but it's not that quick. If a really quick loud sound is generated, like a shotgun blast going off by your ear, even fireworks, some quick sound, a jackhammer, the sound can hit your inner ear before this attenuation reflex kicks in, and you can damage the inner ear from very loud sounds, especially when they come on really fast and aren't kind of ramped up. So I won't test you on that, but I'm sure you know that already. Okay, this concept of hyperacusis, probably know about this already, but if you don't, here we go. It occurs when people are oversensitive to sound. So like the sound of my voice doesn't bother most people. It's not that loud, but in some people who are hyperacoustic, it would hurt their ears. So it's a very strange type of phenomenon. Sometimes we don't know what causes it. Sometimes we do. It can happen in one ear or it can happen in both ears. The mechanisms, definitions are still debatable. It's often associated with people who have tinnitus as well. What is the cause? Again, it's debatable, but the auditory neurons that we talked about might be hyperexcitable, similar to people with chronic pain. Their pain fibers, their incoming pain fibers tend to be hyperexcitable. A lot of psychotic disorders are associated with this, including severe depression disorders, anxiety, obsessive compulsive. Those people tend to get this more than more regular people. People with dysfunctional attenuation reflex. So if you have a neuroma, which is a tumor on the nerve, or you have a tumor next to a nerve that's compressing a nerve, any injury to 5, 7, and 8 could cause hyperacusis because that protective mechanism we talked about, that attenuation reflex, is out of action. So the sounds are going to seem too loud. Another thing is so we said that the Stapedius muscle is the most important for that protective mechanism. And that is often damaged in a condition called Bell's palsy, which I know you've studied about before. So that's one of the things. If somebody is battling Bell's palsy and recovering from that, you need to test their hearing and see how they're doing. Are they having trouble with loud sounds? Okay, there's the classic Bell's palsy, right? Damage to the facial nerve. So you lose all the muscle tone and occipital frontalis muscle here. The muscles that surround the eye, orbicularis oculi, palpebral divisions, are out of action, so it makes the eye relax and open too much. And then, of course, I haven't taught Gross 2 in anatomy in, 4 or 5 years. I'm trying to remember the name of all these muscles around the mouth here. Risorius, I know that's one. But those muscles allow the corner to droop down like that. Okay, there's some subcategories of hyperacusis based on patient's symptoms. Some people just have excessive loudness and it drives them crazy. Some people it's more of an unpleasantness. It doesn't bother them that much. Some people have flat-out pain with various degrees of volume of speech. Loud speech will affect them. And some people get almost a phobia, a fear of like 4th of July. They're terrified. They don't want to go out on that. So they can get very fearful of sounds. Some more fun facts. There's Metallica, in case you don't know who that is. Some risk factors here. One huge one is long chronic exposure to loud music. And I'm not talking 110 decibel concert, which they don't do anymore. They used to back in the day. But I'm talking about decibels that over 90 decibels. So you have to be careful when you practice. I actually have a sound gauge, so I know exactly how loud my little guitar room is here. I try not to go over 80. I try to stay under 80. It's really easy to go over 90, and I could probably do that for hours and wouldn't bother me. So it's easy to develop this, but people who are exposed to this have a much higher rate of hyperacusis later in life. And those who have battle hyperacusis, they have psychiatric conditions. They also have an increased prevalence of low back pain, fibromyalgia, and chronic fatigue syndrome. All these kind of nebulous things that we don't really understand, which I think it's just people are wired. They have hypersensitive nerves, or maybe their density of nociceptors is greater than other people's. What about treatment? Very difficult to treat this. Of course, if it's a neuroma or if it's a tumor, like a lipoma compressing the facial nerve, or you can decompress the nerve, get rid of the tumor, so that's got good hope of fixing it. Then there's desensitization training, where exposure to, you kind of desensitize yourself by listening with headphones. Not crazy loud sounds, but you start out with very low noise, like white noise, like static, and you listen to it 8 hours a day maybe. I don't know what the exact parameters are, but you increase that louder and louder, and you just kind of get someone used to it. They recommend not wearing earplugs. You don't want to ever have these people have a super quiet environment, because when they take the earplugs out, then things get noisy again. Cognitive behavioral therapy, which you learn about in psychology, or kind of retraining therapy. And this is good for chronic back pain too. Some people who've had surgery, they're going to always have chronic back pain. And these psychologists work on changing the way someone thinks about whatever disability or chronic pain or hyperacusis, whatever it is. They try to change the way you think about it, and reduction in anxiety for people who have that problem. Okay, so let's see, one kind of random slide here. Didn't develop this line too much, just didn't have time. But there is a transmission of sound. Those sound waves can also get into the cochlea, not through the external and middle ear. They can get into the cochlea right through the skull. So sound waves can travel through the bone of the skull and vibrate the cochlear fluid. It's typically a terrible way. You can't hear basically anything, so you can't hear sound, but you can kind of hear muffled type sounds. There are some special electromechanical sound amplifying devices that can take those skull vibrations and amplify them to the point where you can hear. People who are they're like they have no auditory ossicles or whatever their problem is. There is a way that they can hear through this mechanism. Okay, let's talk about a couple of diseases, and then we'll call it a quarter. So Cholesteatoma. This is the weirdest word. Okay, this is like thoracic outlet syndrome, when the problem is not at the thoracic outlet, it's really at the thoracic inlet. This is another kind of brain fart, I think, when they named the disease. Because if you look at what this cholesteatoma means, it really means a fatty bile tumor. And this has nothing to do with that. So it's a misnomenclature. Yeah, it's just a bad word, but nevertheless, it's stuck with us. And the bottom line, what is it? It occurs when, remember we said we have keratinized, we have regular skin here, keratinized stratified squamous epithelium that lines the auricle and the external acoustic meatus and the lateral portion of the eardrum, but never the middle ear. This is mucous membrane lines the middle ear and lines the auditory tube. So what cholesteatoma is is when this skin starts to grow inside the middle ear. Okay, now think about that for a minute. Why would that be a bad thing? Somebody email me right now. Why would that be a bad thing? Well, what does skin do? Well, we said keratinocytes. We said in dermatology. Have you had? Oh, yeah, I actually teach you that, don't I? Yeah, we said that. Keratinocytes are born about every 23 days, or they die about every 23 days. That's the life cycle of a keratinocyte, which is created by the stratum basale cells in the stratum basale, or the basal cells. They slough off, don't they? And they become, I don't know, dust floating around your house, and you take a shower and you scrub them off. What if that happens in the middle ear? There's no way to get rid of it. In here, they are blended in to the component of earwax, and they come out with you using a Q-tip, or I guess I'm not supposed to tell you to ever use a Q-tip, but they come out. Get rid of them. Here, there's no way to get rid of them, and they build up and build up and build up, and they cause inflammation. It's almost like a cancer growing in here, and that's what it is. And yeah, recall the shedding. That shedding of the skin is called an exfoliation or a desquamation. And that's what occurs. Remember, yeah, that's all I want to say there. I've already said that, but here's the stratum basale. Okay, so basal cells, they split and create a new cell, a new keratinocyte. These are stem cells. They split again and create another one. And these are pushed up and up and up. Of course, there's many layers here. This is just a cartoon. But after about 23 days, they slough off. And those are called squames, these dead keratinocytes. And that would be very bad. In the middle ear, you have a mucous membrane. And the mucous membrane is made up of a stratified squamous, but it's non-keratinized, and it's a non-desquamating, and it's non-shedding. It's a special type of cell. The basal cells are not active in that type of cell. There's just tons of goblet cells. So you do make some mucus, but that's it. Then there's a basement membrane and connective tissue, aka lamina propria, connective tissue. That's what a mucous membrane is. So there's two types of cholesteatoma. There is the congenital type that you're born with. This is an embryological development problem where the skin, I'm just going to call it, that's the keratinized stratified squamous epithelium. I'm just going to call it skin. The skin develops in the middle ear, and there's a mess up with embryology. Then there's the acquired condition, which is the most common. And the pathophysiology is not understood. There's two main theories of this. The first one is it's caused by chronic middle ear infections. And anytime you get a bug in your middle ear, your body sees it and fights it, and inflammation occurs. And the inflammation, the sequelae of the inflammation over and over and over, the native mucosal layer morphs. It morphs into a regular type of skin, which is maybe better adapted. So it's kind of like a metaplasia in a way. Okay, so that's one theory. Chronic inflammation morphs the mucous membrane into skin. Another way is from someone who has a perforated eardrum, which, by the way, will grow back. If you puncture your eardrum, it'll grow back in most cases. But people who've had a punctured eardrum, there's a hole between the outer ear and the middle ear, and they think as the healing occurs, some of the skin kind of goes through the eardrum and gets into the middle ear. All right, and yeah, the accumulation of those dead keratinocytes, if you have real skin in your middle ear, accumulation of those dead skin cells, which again are called squames, or you could call them dead keratinocytes or dead corneocytes. Those are all keratinocytes that have went through their life cycle. They're dead keratinocytes. Most of the time they call them squames. But yeah, if you get a buildup of squames, dead skin cells in your middle ear, it can compress the auditory ossicles so tightly that it cuts off their blood supply because those auditory ossicles are they're living bone. And so if you compress their blood supply, the bone dies and you get necrosis of the bone. And parts, maybe not all of the bone die, but regions of the bone die. And who's going to clean up the dead bone? The body's inflammation process will. So body spots the dead bone, sends in the troops to clean up the area, and the scar tissue can ankylose those joints so you don't get any movement there. Sometimes it completely destroys the bone so it just disappears. There's all sorts of possibilities. Sometimes we saw an example of a calcified joint a little while ago. So yeah, major hearing loss occurs. You have to yell at the patient so they hear you at all if those auditory ossicles are out. And that's everything. Oh, this is another thing that happens, another theory. Because not only does it destroy the ossicles, the auditory ossicles, but another weird thing, that inflammation tends to recruit osteoclasts into the adjacent bone. And we don't understand the mechanism that, but we know what osteoclasts do. They destroy bone. And so if you don't treat and get rid of that squamous, don't get rid of that skin inside the middle ear, the osteoclast activity can become significant, and it can actually destroy the temporal bone, and it can destroy the mastoid, and it can even get into the facial skeleton and destroy your face, and it can get into the cranial vault and destroy that. And there's even cases where it's gotten all the way down into atlas and axis. So it almost acts like in a cancer type of thing, even though it's not the dead squames causing it. Somehow it's stimulating osteoclastic activity, and we have no clue why that happens. So very, very strange condition. All right, a couple more here. Got to just we'll end with otitis media. So media that's the middle ear. That's an inflammation. Could be acute or chronic. So this is just a middle ear infection, which is almost always seen in kids. Very rare for adults to get this. But in kids, why is that, by the way? I don't think I put that slide in there. Because in adults, your station tube is wide open. So if bugs start to crawl and head toward the middle ear from the oropharynx and head in, remember there's that mucus escalator system, conveyor belt that is heading out from the inner ear outward toward the back of the nose, the nasopharynx. But in little kids, that tube is very, very tight, and that mucus escalator system doesn't work. So bacteria can really get a population growth in there because of that, and it can spread into the middle ear very easily. All right, who's the bug usually? It's usually a double. It's usually virus first, then followed by bacteria. But it usually starts as a virus, which produces a serous exudate. So you get a fluid starting to build up in the middle ear if this is going on. And then later, after the virus gets a foothold, bacteria can come into the area as well. And then the common bacteria are Streptococcus pneumoniae and the Haemophilus influenza and the Moraxilla catarrhalis. And those are the big three. So you got a virus and you got one of these three bacteria in there as well. And bacteria leads to a suppurative exudate and inflammation. And so, so your body can usually clean this up. You get an infection, you have an earache for a while, and usually feel better. But if this happens, and that's acute otitis media, which I just described. But if this happens over and over, you can start to get little pockets of bacteria that are resistant. You feel better, but you still have a smoldering infection going on. And that can flare up the acute phase of the disease real easily if there's already a population that you haven't completely snuffed out. And so that leads to chronic disease. And the chronic bugs are, the the same one, or no, Pseudomonas aeruginosa and Staph aureus and certain fungi won't worry about it. But there's some more bugs that can cause it. I'm not so interested in the bugs. But yeah, so if you have these chronic infections, you can perforate the eardrum. Enough inflammatory juice can fill up the eustachian tube or fill up the middle ear. And in little kids, especially if the eustachianary tube is closed it's already narrow to begin with, but it can be closed really easily. There's nowhere for the infection to go. It can't really go into the mastoid very much. There is some that can get into the mastoid, but it's easier to blow out the eardrum. And that typically happens. The eardrum ruptures and you get inflammatory juice running out of the ear, which is an indication that the eardrum is ruptured. And yeah, it can damage the auditory ossicles. It can if it gets into the inner ear, which we didn't even have time to get to, but it can damage the labyrinth. It can get into the mastoid air spaces and cause mastitis, which potentially could get into the brain. So it causes cerebritis. So yeah, you got to take these. You're going to have to take antibiotics for these things because you don't want to mess with them. Otitis media. You can see kind of winding down. These slides aren't very developed because I just made them today, some of these. Infection, inflammation of the inner ear. There's two types. There's acute otitis media, and there's another type of otitis media called otitis media with effusion. I think we're going to get into much more of this. The acute otitis media, risk factors for developing this are an anomalous eustachian tube anatomy. We said little kids is very narrow, but you can be born with a eustachian tube which is more amenable for bacterial growth. If it's shorter than normal, if it's more narrow than normal, if it's more horizontal, then gravity can't help it drain. So all it takes in these cases, it just takes a little inflammation and you got yourself a rip-roaring inflammation. It's going to swell the mucous membrane and close that tube down. Now the bacteria are really going to breed like crazy. Most common reason, fun facts here, I guess. Acute earache, acute otitis media is one of the most common reason children seek medical care, really parents seek medical care for their children. Symptoms of a child having an earache, look for kids and babies who can't even talk yet. They'll be pulling at their ear. I have 5 kids, so I know this sign well. They pull and tug and scratch at their ear. They may have a fever as a byproduct of the inflammation that's going on. If you see juice coming out of the eardrum or otorrhea, that's inflammatory juice coming out, you know that the eardrum is ruptured. And don't worry, it will heal up, but maybe their hearing won't be quite as precise as if they wouldn't have had a rupture there. And then if you look in their ear, you'll see changes to the membrane, the cone of light. I think we talked about how infections of the inner ear, all the swelling and pus and juice can bulge the tympanic membrane outward instead of normally it's kind of pulling it inward. And then you'll lose the cone of light reflex. I think Dr. Palmano probably went over that with you in lab, so you know a little bit about that. Treatment of broad-spectrum antibiotics, you got to figure out what the bacteria is and kill it. And they go after these 3 because they're so much more common. And some anti-inflammatories because the inflammation usually overdoes it. And yeah, for those with chronic infections, you may need a year worth of antibiotics to get rid of it, but you've got to get rid of that thing. And then I think this is where I stopped it right here. Ear tubes are very common. Myringotomy tubes, they're called. One of our kids had these. And they punctured the eardrum and they put a plastic little tunnel, little tube in there so the pressure will never build up inside their ear. And you can take these out later. You don't leave them in forever. But to someone with chronic ear infections, the thought is they probably have a smoldering chronic infection you can't get rid of. And if you can just equalize the pressure between outside and the middle ear and kind of cool things off. You can imagine how hot it is inside there with the pharyngotympanic tube closed, and there's nowhere for it to breathe. It gets really hot, which is a perfect breeding ground for bacteria. All right, here's just which ear is this? You guys should know that. Cone of light points forward like a headlight on a car. So this is the left ear. This is normal. There's the handle of the malleus. There's the umbo. And here you've lost the cone of light reflex. The eardrum is bulging out toward us. It's hyperemic. Look at all the blood vessels. This is chronic otitis media. Or maybe acute. It could be acute as well. I don't know the history, but that is not normal. All right. I don't know where I am on birds with you guys. I'm all mixed up. But there's a red-tailed hawk. If I put that on the test, you think you can handle it? Especially if I left that on there, red-tailed hawk. No, I won't leave that on there. But yeah, the tail's pretty red. All right. Wish I had more time to prepare this class, but this was the best I could do with just basically stepping in with no notice. All right. I guess I won't see you guys. Dermatology, we'll see you. All right. Bye-bye.